Alright, we're going to be doing a crash course on aortic stenosis. We're going to be defining the pathology of the assigned disorder, the clinical manifestations of the disorder, the impact of the disorder on organs and their systems, and aspects of the head-to-toe assessment that would be most helpful when caring for a patient with this disorder. My name is Stephen Dale, and this is...
I'm Bailey Altman.
And I'm Jennifer.
Hi there, my name is Jennifer, and I'm going to be covering the pathophysiology of aortic stenosis along with the impact on organs. Your aortic valve is located between the heart's left ventricle and the aorta, which is the main artery carrying blood to the body. In aortic stenosis, the valve becomes narrowed, and when this opening narrows, the blood flow is restricted and forces the heart to pump harder to circulate blood. This narrowing can be due to scarring and buildup of calcium in the valve flap over time, and this is primarily what we'll see in the older populations. It can also be due to contracting rheumatic fever in childhood, or it can be due to a birth defect where only 2 cusps or heart valves grow instead of 3. If left untreated, aortic stenosis can progress and create problems not only with the heart, but with all of your other major organs. Within the heart, there is an increase in workload with aortic stenosis that causes the left ventricle's muscular wall to thicken. And this is a condition called ventricular hypertrophy. This thickening is initially a positive adaptation of the heart to maintain and adapt to perform properly. However, over time, this hypertrophy can lead to further complications such as decreased ability of the heart to relax and fill, increased oxygen demand and arrhythmias, and even heart failure. Within the lungs, with aortic stenosis, it causes the heart to pitch harder to move blood through the narrowed valve, and the pressure inside the left ventricle increases. And this extra pressure then backs up into the blood vessels in the lungs, and as the pressure in the vessels rises, the pulmonary hypertension can develop, as well as a pulmonary edema. Fluid can leak out into tiny air sacs, the alveoli, in the lungs, causing a buildup of fluid known as pulmonary edema. And pulmonary edema can cause severe shortness of breath, coughing, and in severe cases, respiratory failure. Severe aortic stenosis creates decreased cardiac output that can impair blood flow to the brain as well. This can potentially cause dizziness, fainting, and in severe cases, strokes due to blood clot formation or emboli from the calcified valve. For the GI tract, the stress from narrowed aortic valve can trigger a chain of events that leads to bleeding from the angiodysplasias in the GI tract, making aortic stenosis a potential risk factor for GI bleeding. Reduced blood flow from the heart can impact the kidneys and potentially lead to chronic kidney disease. And in the liver, right-sided heart failure resulting from advanced aortic stenosis can lead to hepatic congestion, where the blood backs up into the liver, potentially causing liver enzyme elevation and developing into cirrhosis over time.
Clinical manifestations of aortic stenosis. Aortic stenosis is a condition characterized by the narrowing of the aortic valve, which leads to the obstruction of blood flow from the left ventricle to the aorta. This obstruction often develops gradually, allowing patients to remain asymptomatic for 10 to 20 years. When symptoms do manifest, they commonly include exertional shortness of breath and fatigue. A characteristic heart murmur may be detected during auscultation of the heart. Palpitations are often described as transient episodes of rapid or irregular heartbeats. As the disease advances, more serious symptoms such as chest pain, episodes of syncope, and signs of heart failure can develop. Aortic stenosis is characterized by the increased left ventricular systolic pressure, prolonged ejection time, and elevated end diastolic pressure. These changes lead to the left ventricular hypertrophy, which in turn increases myocardial oxygen demand. Eventually, the left ventricle may deteriorate as it becomes unable to meet the body's oxygen requirements. Additional clinical manifestations can include paroxysmal nocturnal dyspnea, such as waking up gasping for air at night, dizziness with exertion, palpitations, chest pain relieved by rest, orthopnea, and arrhythmias such as atrial fibrillation. Physical examination may reveal small, sustained arterial pulses that rise slowly, a noticeable delay between carotid artery pulse and the apical pulse, systolic hypertension, peripheral edema, and episodes of transient bradycardia. There may also be a delayed upstroke and diminished strength of the carotid pulse, as well as the displacement of the apical pulse both inferiorly and laterally. A palpable heave may be present at the apical site due to increased force of left ventricular contraction. In severe cases, aortic stenosis can cause significantly prolonged ventricular ejection time, which delays the closure of the aortic valve so that it occurs after the pulmonic valve. This reversal of the normal valve closure sequence, referred to as paradoxical splitting of S2, is most prominently heard during exhalation and disappears with inhalation. Diagnostic imaging findings further support that diagnosis. Chest radiography may reveal valvular calcification, left ventricular enlargement, and pulmonary venous congestion. Echocardiography often demonstrates thickened, calcified aortic valve leaflets, a reduced aortic orifice, and decreased valve area. Electrocardiography typically shows increased QRS voltage as a result of the left ventricular hypertrophy.
Okay, now let's take a look at what aortic stenosis does to the body and what we would assess as nurses. Starting with the cardiovascular system, when the aortic valve narrows, it creates an obstruction for blood leaving the left ventricle during systole. The heart has to work harder against that resistance, which leads to left ventricular hypertrophy as a compensatory mechanism. Over time, the muscle's oxygen demand outpaces the coronary supply, resulting in myocardial ischemia and angina. This also decreases the stroke volume and reduces cardiac output. Moving into the pulmonary system, incomplete emptying of the left ventricle causes blood to back up into the left atrium, which increases hydrostatic pressure in the pulmonary veins and the capillaries. This could lead to pulmonary edema and symptoms of dyspnea upon exertion. For the neurological system, with each heartbeat, less volume is ejected into the aorta and its branches, which decreases cerebral blood flow. This can cause dizziness and syncope, especially with activity. Overall, systemically, prolonged severe stenosis can progress to heart failure with clear signs of low perfusion, and patients often report persistent fatigue from reduced oxygen delivery to the tissues. When we are assessing a patient with aortic stenosis, we typically start with subjective findings. Common complaints can include fatigue, dyspnea, or syncope with exertion, palpitations, dizziness, and angina or chest pain. On the objective exam, we may notice pallor and other signs of poor perfusion, such as cool, pale skin, delayed capillary refill, and weak peripheral pulses. In some severe cases, confusion or decreased level of consciousness can appear from reduced cerebral perfusion, and oliguria may indicate decreased kidney perfusion. Vital signs may show low blood pressure or a narrow pulse pressure, as well as changes in the heart rate. The pulse assessment will often show a slow, diminished radial pulse. Upon cardiac auscultation, the hallmark murmur is loud, harsh, and mid-systolic with a crescendo-decrescendo pattern, meaning a general increase in loudness followed by a general decrease in loudness. It's best heard at the second right intercostal space during full expiration with the patient leaning forward, and it often radiates to the carotids. A systolic thrill may be felt at the right intercostal space or the sternal notch. S1 is usually normal. An ejection click may be present, and in some cases you might hear a paradoxical split, S2. And on a respiratory exam, you may hear crackles or rails if pulmonary congestion is present. Aortic stenosis is a complex condition, and people are often asymptomatic for 10 to 20 years. In nursing care, early recognition of symptoms and changes in perfusion can save lives.